Hi everyone, welcome to this week's lecture, Geriatric Psychopharmacology, or also Drugs in Older Adults. I'm gonna be your lecturer today, hi, and if you have any questions, please feel free to email me or Dr. Cowan, and we're happy to help you out. So this week we're gonna have two lectures. I'm going to start with some general stuff on aging, and then we're going to have a guest lecture on Alzheimer's disease. And then Thursday, there's going to be a guest lecture on Parkinson's disease and a little bit more about the general aging and psychopharmacology. So yeah, again, if you have any questions, feel free to email me. Other than that, yeah, enjoy. Okay, so why is it important to study older adults compared to younger adults or infants? Why are they important? So older adults, which is individuals that are 65 years or older, they account for a majority of prescription drugs as well as over-the-counter drugs. And a recent study from 2015 found that the median, so the most frequent number of prescription drugs in older adults is 4. So a lot of older adults take 4 prescription drugs in a week or more, which is a lot. I mean, I take 0 prescription drugs. And so two important things that are different from older adults are, one is metabolic changes. So for example, they have decreased liver enzyme activity, which means that the metabolism of drugs can be slowed down. And a second factor are physiological changes. For example, older adults are more prone to suffer from motor impairments or any side effects from drugs that may act a little differently on them. So for example, if a very common side effect of antidepressants would be weight gain, which is not very desirable for younger adults, but maybe for some of the older adults that's actually desirable because they have trouble maintaining their weight. And so for a lot of those reasons, it's really important to study older adults individually. All right, so what is inappropriate drug use in the elderly? So just to clarify, I'm going to use older adults and elderly interchangeably throughout the presentation. Both refer to any adults that are over the age of 65. So what is this inappropriate use? It's called polypharmacy in the elderly, and that means that they take more than one drug at the same time. So 64% of the older adults take at least one dietary supplement, and then 39% actually take 5 or more prescribed drugs. So 4 is the median, but there's still a lot of people who take more than 5. And this is important because only 14% of the American population is 65 or older, yet they account for so much drug use, and they're prescribed so many different drugs. So check out that link if you want to learn more about that. And so because they use so many different drugs at the same time, it is estimated that there's between 20 or 40% of cases that are inappropriate prescription. So what that means is that they're prescribed a drug that's not really treating the symptoms that they're showing, that has maybe side effects with other drugs that they're prescribed, or that are just not giving them the ideal care that they need. So this inappropriate prescription use can lead to suboptimal care. And also, it has been shown that many symptoms, such as psychomotor symptoms or cognitive functioning, actually improve when this inappropriate drug use is stopped. So, especially given the some of the symptoms that older adults show, such as memory decline or cognitive function decline, those could actually be explained in part by inappropriate drug use. So it's really important to know that and to be aware of the fact that maybe your elder patients are having more trouble using the correct drugs. So what can this inappropriate drug use lead to? First of all, there can be cognitive inhibition, which means just a decline in general cognitive functions. And worst case, this can lead to drug-induced dementia, which means that a patient is incorrectly diagnosed with dementia or shows severe symptoms of dementia, even though it's can be reduced to the misuse of a drug. And there's also unwanted sedation. This is really important because older adults, based on their different physiology compared to younger adults, are more likely to suffer severe consequences, for example, from falls and fractures, and they're less likely to recover full mobility from those. And then another one would be bizarre behaviors in our drug-induced delirium. So they would just act really, really weirdly, but not because of any cognitive impairment, it's because of the drugs that they're taking. And therefore, this inappropriate drug use really should be avoided. Again, they have a slightly different metabolism compared to younger adults, so that should be considered. And overall, a good guideline is start low and go slow, which means if you want to treat an older adult with a specific drug, you start on a low dose and then you slowly increase that dose if it doesn't show the effects that are wanted immediately. Those are, of course, guidelines for caregivers or doctors, not necessarily for us, but it's important to know that these guidelines exist to treat older adults with drugs without misusing or inappropriately treating them with drugs. Okay, so what is dementia? Dementia is an umbrella term for impairments in memory, reasoning, or other cognitive functions, for example, language, decision-making, many more. And it is so bad that this decline affects the daily life of the affected individual. And dementia is generally caused by damage to neurons or to just a degradation in neurons, and it's not part of normal aging. Another important feature of dementia is that it worsens over time, so the decline gets worse over time. Dementia is kind of an umbrella term for many things, and one of the big parts of it is Alzheimer's disease. So Alzheimer's disease and dementias are sometimes used interchangeably, but they're actually not the same. So 60 or 80% of Alzheimer's cases lead to dementia, but dementia is really just referring to a subset of symptoms, whereas Alzheimer's disease is a very concrete, specific disease. And we're going to hear more about that distinction when we come to the Alzheimer's lecture. And here's just a little graph to show that a little bit more. So on the x-axis we have years, on the y-axis we have cognitive function, and so we can see that at the beginning of the graph, cognitive functions are at their maximum, which is just normal performance. Of course, that's for adults. And then we see the dotted line would be dementia. So we first see a preclinical stage where we cannot really dissociate normal aging and dementia. Then we see a slow decline over time compared to normal aging, which eventually leads to MCI, which means mild cognitive impairment. So we can see some form of impairment, but it isn't too different from normal aging yet. But then over time, it gradually gets worse and worse, and we have a really dementia case. Again, the straight line would just be normal aging, so we still see a decline over time, but it's not in the slightest as bad as for dementia. Yeah. Okay, so one very important part of dementia would be controlling agitated and aggressive behaviors, especially in individuals that are in caretaking facilities. So those who really need daily care also need to be somewhat complying with that care. So some of the core symptoms of dementia are agitation, which would be pacing or wandering, just being restless and not being able to sit long enough to eat, for example. Again, it's really important that those things all interfere with the ability to have a normal daily life. There can be verbal or physical aggression, especially against caretakers or against other people who are at the facility. There can be physical resistance and non-compliance with care, which of course is really difficult and makes it both more expensive because it takes more time and also more difficult to care for an individual. There can be hallucinations or delusions for psychosis. There can be depressive symptoms such as apathy or just a lack of interest in general. There can also be inappropriate sexual behavior, both verbal or physical, and sleep disturbances. One example of that would be a reverse day and night schedule. So being very sleepy throughout the day, but then being very awake at night. And so one way how these behavioral and psychological symptoms of dementia, short BPSD, are treated is by using antipsychotic medications. This has been done very frequently in those caretaking facilities. However, in 2005, the FDA issued a public health advisory warning people because some studies found that there's an average 1.7 times increased likelihood to die compared to placebo when taking antipsychotic medications. This is still controversial because some studies failed to replicate this increased mortality rate, but other studies did replicate it. So the FDA currently still has a black box warning for this use of antipsychotic medications. However, the risk may depend on the drug that is being used and the dose that is being applied. And they're still used in caretaking facilities, but the use has declined from 2006 to 2010, and I think it has declined even more in a more recent study. I think it was about 14% then. And yeah, there are several initiatives to reduce using these antipsychotic medications in the absence of the medical indications to do so. One of those campaigns I linked up here for you to look at. So overall, research suggests that if there's just minimal or weak effects in treating symptoms of BPSD with antipsychotic medications, especially in individuals with dementia. And so there was one study who found that the risk-benefit ratio for atypical antipsychotics in patients over 40, which is not even just older adults, it's also just adults, is not favorable regardless of diagnosis or drugs. So they observed incidences of metabolic syndrome, which would be something like high blood pressure, high blood sugar, excessive body fat, and abnormal cholesterol levels in 36% of people. And they also saw serious and non-serious adverse events occurring because related to the drug, while there was no improvement of psychotic symptoms. So generally, it is advised that antipsychotic medications are only used as a part of a treatment package, meaning like together with behavioral and other interventions, and short-term unless the symptoms re-emerge. Okay, now something a little bit different. This is about depression in the elderly. So depression in older adults is underdiagnosed and inadequately treated. What that means is that older adults have the highest rate of not receiving mental health treatment, but simultaneously they also have the lowest rate of perceived need for treatment. So a lot of older adults don't think that they actually need help, even though they do. So here in this graph, you can see the suicide rate for males by age group in the United States. In blue, we see 2000, and in green, we see 2016. I also put the same graph for females here, which is at the bottom, but it's generally a lot lower than males. So what we see here is that for males 75 and older, there's really an increased risk of suicide. So per 100,000 inhabitants, there would be 39.2 cases of males committing suicide in 2016, which is frightening high, not just in general, but also compared to the other groups. Okay, so what antidepressants are used in older adults? There's a couple of them that I listed here that have been shown to be effective in older adults. There's also a meta-study from Koch et al. In 2011 that showed that it's really important that the treatment with antidepressants in older adults is continued because it's really helpful in maintaining the recovery. However, again, there's a low response rate to treatment and then an increased risk for comorbidity and mortality by using all of those antidepressants. For SSRIs in dementia patients, we also see an increased risk of falls, which like physical falls, so them falling, which is a problem because again, they're less likely to recover from those kinds of incidences.